Chairman, dear auditorium, thank you for the invitation to this meeting. I represent you in the next 10 to 15 minutes an overview on the genomics part of instruments of neurosis, and we are focusing in our lab, which is Golubnitschaja, the Life and Medical Science Institute, just 200 meters from here, on especially on genomics. So when you want to see the advantages that we are taking from the genomics area, I think it's a good idea to spin some decades back and see what else has brought us to the point where we are now in breast cancer. And very importantly, there are a lot of surgical studies that were done in the starting from the 1960s that compared patient characteristic, and thus were the first examples of some kind of personalized medicine in breast cancer. And in the late 80s and in the beginning of the 90s, then with the start of the genomic area, we found that breast cancer indeed is a much more heterogeneous disease than was thought before, and this was one of the articles that showed that indeed breast cancer has types of amplifications that might distribute patients with bad and good prognosis. So this was the point where we started in the genomics area around the year 2000. We knew that breast conserving surgery is feasible for the majority of breast cancer patients, although it wasn't clear for which especially. We knew that sentinel node biopsy is feasible in the small breast tumors, but also here it wasn't clear why some small breast tumors already have sentinel node metastasis and some have not. There was in estrogen receptor positive breast cancer the start of the Cebioglu therapy, and in the HER2 positive breast cancer they started with the first studies on special medication against this receptor. But, and this is not only true for the year 2000, but also for now, it was still clear that breast cancer is a heterogeneous disease. So, this is the current clinical pathologic decision making, and this hasn't changed too much in the last years. So you're having a variety of different staging and grading systems where you personalize your treatment of your cancer patients, and you put the patients in a good prognosis, in intermediate prognosis, and in a poor prognosis group, and you adjust the treatment of the patients according to that. So in the year 2000 then, there was a big article from Peru in Nature that for the first time used novel technologies, and in this point it's a class slide where you can measure several 10,000 of genes, and they use this to allocate breast cancer samples into different types. And what they came out with is, in general, it's 6 groups. You have the basalites, you have the HER2 positives, you have luminal A, B, and C, and you have the normal breast-like tumor type. And next, it was asked whether these types already have if this has an impact on survival of patients. And what you see is that indeed you have different types of tumors that show different survival, and especially here you have the HER2 positive ones in the basalites that have a very bad prognosis. So this was the start of the gene expression-based prognostic profiling, and people thought now it's possible with this technique not only to allocate patients into different types of tumors, but also to allocate patients into different prognostic groups. So if you use this technique to allocate patients according to gene expression profiles, you can easily get a good prognosis and a poor prognosis group, and you can discuss whether it's useful for the good prognosis group to skip chemotherapy and for the poor prognosis group to use chemotherapy and then